that be nice?
Yes, that would be lovely.
Good afternoon and welcome to the Human Services Committee meeting. Is there any courtesy of the floor?
There is. I told Suze has a little work here to do, so I told her I'd read her letter for her. Now, this is dated May 12th, 2023. Dear Susan, this letter serves as approval to terminate the agreement between Northampton County, the State Civil Service Commission, SCSC, the Office of Administration, OA, yes, so we're out of civil service. We'd like to thank Dr. Valerie Arkush, the Secretary of the Department of Human Services, Dr. Latika Davis-Jones, the Acting Secretary, and I believe now the Secretary of DDAP, and Jason Kavulik, the Secretary of Aging, along with Georgine Kapora, who was instrumental in the long journey of getting Northampton County out of civil service. And of course, I'd like to thank Sue, who, our Director of Human Services, who didn't think she'd live to see the day that Northampton County was out of civil service. And I'm sure during her report, if you have any questions for her about the ramifications of this, and they're all positive for us, she'd be happy to answer them. Thank you.
Any other courtesy of the floor? And next, we have the demonstration of decision aid and supervision tools by the Director of Human Services.
So I could easily fill an hour, so I'm happy to go first, but if you would like to have Graysdale go first, I just wanted to present that as an option to you.
Committee members, what would you prefer? Okay, let's do Graysdale and then, or do you want to talk and take a break and then talk? I mean, do you need a voice break? Thank you, sir. Okay, then let's move Graysdale up.
Yes. Good evening. So the first thing I want to do is I want to announce that Stephen Carl has received his nursing home administrator license. He just passed the test last week. Been studying very hard. So I wanted to do a report on Graysdale. I also have an update on our survey and also an update on Affinity. So we'll go through the report first. So you can see the average census is 415. This is for May. We currently have an average census of 430. You see the referrals, admissions, pending admits. Then you can see on the next page, when you're ready, is our census versus PPD. We average around 3.3 for our PPD, and then obviously 415 for our census. The next page are some of the rules that changed on July 1st with regards to staffing. I've been putting this every month in our report just so that you remember that it all had changed. The PPD now is 2.87 and 3.2 next year. It'll be going up to. It is based on PPD and acuity level of them, ratios.
Jan, when does the year start? July, or when you say it goes up next year?
The same time next year, July 1st.
Thanks.
Then you have your comings and goings from April to May. So we had 20 in the positive, and we did have 19 through different reasons, no call, no show. We had some retirements from the CNA, dietary department, fiscal retired. The 5-star rating is the same for May as it is currently. We have 3 stars, still 4 stars in our health inspection. Quality measures is a 1. We are working on that now because the measures changed, so we are aggressively working on that. And we've gone up to the 3 stars, which was our PBJ for almost a year that did not reflect because there was that hiccup with the computer. It talks about our usual influenza vaccine rates, our COVID cases, which were almost nil in May. We only had the 1. Goes into just a little definitions about what pressure ulcers are versus wounds. So I just always put that in here as well, just so you have. Our wounds for April were 7.5%, and those are usually hospice residents, those with poor nutrition intake. Our dietitians are very much involved in, as well as the treatment team, in the care of the wounds. This is our monthly stats for call-offs. So you can see how many call-offs, they've been trending down. June, we're up a little bit, but holiday season, warmer weather. And then the next page goes over our billing days. So you can see the, how much we're getting paid again through the rate 1, rate 2, and rate 3. That combined give us, between the 3 CHC payers, 652, 656, and then the 652 again. So that's our income coming in. So then on the next page, you see what our O&M department has been working on, which you have given us the money for last year. See the new nurses stations. The one center picture with the trees was how we had to take out one of the elevators out through the roof of the 10-story building. That was, residents love to watch that. We have the garden area in the back of the buildings that looks like a triangle. So the flooring in the bathrooms that is being done. So I wanted to also say, so with July 1st, 2023, this is all the new regulations that came out to add on to the current regulations that I have that the state likes to give to us in CMS. So I've included the federal tags. So the F tags are what, when a survey team comes in, this is what they're looking to see if we meet these deficiencies on. So this is their list, there's 2 pages there, and they go through to see if we are in violation of any of these F tags. That's their job, we appreciate it. We have a mock survey that's done, so we try to preempt any of these F tags coming to fruition.
Jen, how often do people have to sign or re-sign those things?
Which ones?
Like, so for example, residents' rights or any of those things, do they have, how often do they have to be updated?
Yearly. So the social worker department reviews it with the residents, and we also use the admissions department, who sends out quarterly mailings to mail them out to the staff members, the families.
So the families have to sign off?
They just get a copy in case the resident is not alert and oriented, so the families get the copy of it.
And are they required to send it back to you? Or?
We just note that it was mailed out in the quarterly mailing. I also included a scope and severity. A lot of times, we don't get to talk about what the scope and severity is. So when you get an AF tag, you can get an F626, and then the state sends you a letter saying that's what you're in violation of, and then you get a scope and severity. So you have the alphabet, and then on the letter that you get, it usually tells you a D or an E. Those are usually your standard numbers that you get, letters that you get. And then there's been, so far this year, 56 IJs, which is immediate jeopardy, which is severe for nursing homes. So Department of Health has been really very aggressive in their surveys this year so far. So June 6th through June 8th, we were pleased to finally have our annual survey. And I would like to thank all the staff that had worked as a team for one goal, and that is the best life that our residents can have. I include agency staff in this because without their support as a team, we would have to do less for our community that needs us. So we attended several webinars, PACA conferences, CCAP meetings, PADANA conferences, and we've heard over and over that the survey teams have been out across the state and issuing citations in the teens. So that was becoming the norm. Last year, the PA average in February of 2022 was 8 per facility and 8.6 for the United States across the board. So the Department of Health made it clear to nursing homes that we need to make sure that all pre- and post-COVID pandemic regulations are being followed to the letter. Survey begins before the team comes into the building. They use the data that is reported to CMS to narrow down areas that could be of possible concern. So when they come into the building, they know who they're looking at. So they know what floors they're going to be going to, where the residents are that are, what they feel may be the greatest risk for one of these F tags. So someone who has a trach, maybe a pressure ulcer, uses a brace, may trigger the survey team to look at them more closely at their care versus someone who's alert and oriented and is independent. The survey team meet with the staff and residents. They talk to them. They meet with the residents independently. Survey team then reports back some of the things that they're hearing, if there's any concerns. During the survey's investigation into our care practices, they will find areas of concern and ask us to provide the needed documentation. The documentation ensures that we are following the proper regulatory requirements for keeping residents at their highest capabilities. On the last day of the survey, we get our exit interview, and the ombudsman's invited, Sue and Robin are invited, and DOH reviews their preliminary findings with the team. Some on the survey team noticed a change that has been happening over the last few years within staff and residents at Graysdale. They marked that as a positive teamwork attitude and happy residents. We received 2 citations. First it was 1, but they broke it down to 2. So we got an F676, and it's an activity of daily living. We had a resident who had an order for a restorative nursing program for ambulation. A task was not pushed out to record the time spent with doing the restorative, so we could not prove that it was completed, although we know it was done. So we placed a tracking protocol in place to ensure the delivery. So what it is when the staff, the aides do their work, they have to record it. So they go to a kiosk and they punch in the care that they delivered. There was no task button to say that they walked this person so many feet. So we rectified that and made sure that that was pushed out for that. But that was 1 out of 44 residents that they investigated on that. The other one was FTAG 684, and it was quality of care. Sorry, this is the 44 residents.
What was that again?
It was FTAG 684, quality of care. So there were 44 charts that the surveyors reviewed for wound treatment. The team found that one of our 44 residents had a doctor's order that was not followed for a dressing to be placed on the resident. The wound that the staff had healed and was not discontinued. So that's all that needed to be done. And for some reason, that order was just not discontinued. The leg was fine, the wound was fine, there was no wound, but because that order was still there and no dressing was applied, we got cited for it. So re-education housewide to make sure that all the orders are discontinued and followed. So I'm very pleased with the team at Graysdale.
Was it the same patient?
No.
Because you said they put it together and then broke it apart, something like.
Oh, so what they do is they were just going to put both of those under quality of care. So instead, they broke it into 2 citations. That's it. So I'm very pleased with the team at Graysdale for that.
All right, is she done?
With that part of it, and then I'll do the update for Affinity.
No, go ahead.
Okay.
Okay, let's just do this, because that's a lot. There's a lot to talk about. Go ahead, Ron.
Oh, I'm sorry. On your report, thank you. That's very concise. just curious, how many how many beds are certified at Greystone right now that would be filled and unfilled that are available?
688.
Was watching some of the press conferences out of Harrisburg and also locally about the staffing and the changes at the state, and heard a lot of concern by the heads of nursing homes, including Cedar Brook. How are you seeing that going forward? I mean, the requirements, I guess, took effect now.
January 1st.
And I think there's more effects that follow up then in another year. Yeah, and you had talked, so if you could take a moment, where do you see us, what challenge do you see for us as a county to keep in touch? Because it seemed like some of these places had some real serious concerns.
They do. So again, you're looking at agency usage. These requirements are forcing nursing homes to depend on agency usage, which is expensive. Some of the companies that are still out there are trying to keep the COVID rates, those high rates. And so when you're looking at it, so the state is saying, well, the residents deserve more care, which they do. And we've always strived to be over the we've always done like 3.2, 3.4 for as long as I can remember. In the last decade or so, we saw the nursing started to decrease. There wasn't any interest. It wasn't a vocation that was pushed anymore. So you're starting to see the effects after a decade long of people not getting into the system. You know, you only need a high school education to come and be an aide. Well, there's so many other things that people can do. And it's a tough job. I mean, you're taking care of someone's life. And sometimes it's rewarding, and sometimes, you know, you have people that yell at you and because they're frustrated because they can't do anything. You know, they come into a nursing home and sometimes it's their last place to go and they're frustrated, their loss of independence. Think about any one of us having to give up everything and move into a place where people are coming in and out of your rooms or changing you, and it's not a profession that a lot of people want to go into. It's not glorified anymore.
Right.
Where I think we have to do that, we have to say, because there are certain people that within their own self want to take care of people. It's why you have foster parents. That's why you have all these people that come in and want to care for people. And we have to reach those people because we haven't in the past.
Well, let me ask you, these changes, is it in any specific, and I know CNAs, we get a lot, but did they specify, for example, LPNs, RNs, CNAs? Did they break it down like that, or
Yes.
is it a gross number?
Yes, so that's in the report right here. So it tells you that it's required for a maximum of 1 aide per 10 residents,
1 aide per 10 residents.
and that's 2024. So right,
And is that 1 aide per 10 residents?
on day shift.
And it can be a CNA, it can be,
Well, right, CNA, they say specifically what CNA is, they say what LPNs have to be and what RNs. Now,
I guess we focus on CNAs, which they do a lot of work, quite frankly. But I wonder, how about the LPN and RN numbers? And I know we use agency, but do you see concerns with that?
yes, I think you're seeing, because even the hospitals can't get RNs anymore. They're all going to agencies because they demand a higher pay. They don't have to take health care. They don't have to do a lot of things to work there. I mean, I know I unfortunately had to visit a hospital where I heard one of the nurses who was a regular was like, well, she can't help you because I've got to go get this special equipment. So it's crazy that they just have these bodies in there. You know, the hospitals have employed LPNs. Well, that's great for now, but, you know, those are going to take effect too. Are they going to want to work? They can't do a lot of the things that you need to do in a hospital that requires an RN, in trauma, in surgeries. So where did everybody go?
Okay.
To the
Now,
agencies.
I'm wondering, your current staffing needs per shift. Do you know those numbers offhand? Like, where are we at in terms of what you really need? I know that the night shift is often the rough one, or the middle shift.
Right. So I can get you those specific numbers.
Or you can just-
Yeah, I'll say, I
I'm
can just email them.
curious. I like to keep up on that because. I
Like night
know
shift would
there's a
be an
big swing.
LPN, 3 aides, middle shift would be 2 LPNs on a unit of 50 with 4 CNAs.
But vacancies, right? See, I want to know what, like, where we're at with vacancies.
Okay, I can get you those numbers.
Thank you. That's all I have. Thank you.
Thank you. I appreciate the candid nature of your report about the use of agency nurses. To me, it seems like a cartel that should be busted, but that's,
Harrisburg was going to be looking into it, but that was during COVID and nothing ever came to fruition.
yeah. On the state issue, Medicaid reimbursement, is there an anticipation of any change? I kind of lost track of the state budget. It's late again.
We did. So we did get an increase in it for last year, and they're hopefully putting in a percentage for this year too. I want to say it was like 5% increase, but because we just got a big one last year.
5, that would be, the other question I had was, you mentioned to Mr. Heckman that there's 688 bed licenses.
Correct.
Because of the daycare, how many are we going to lose?
Those beds, so when I had to submit for the daycare, I had to move those beds into our existing rooms. And we fit, because we had used rooms for storage that happened 2 decades ago. So they took rooms and used it as blanket storage. Well, those rooms are utilized now as rooms.
So even with the daycare, there is still potentially 688 beds that would be available?
Oh, we were a facility of, 725 when I first came in, but I think it was even higher than that. I think it was 8 or close to it. Yeah. So we do have the rooms. I mean, those were days when I first started, in a very small room, you had 3 beds lined up and it was like walking through like this. So no, those days are gone. There's plenty of room. Those beds have been reallocated.
Okay. Then my other question was quality measures. I think that seems to be a sticking point. What are you doing to address that? And bring
So I had addressed that, I think it was 2 meetings ago, where we talked about one of the biggest problems that we had were rehospitalizations. We are always, and always have been for decades, very cautious with people. So when something occurred, they would go out to the hospital. And anybody who works in a hospital or works with doctor's offices, you know that insurance companies kind of penalize you now for sending people out to the hospital. So we have regrouped and started a process through our supervisors and our doctors where if an RN or a charge LPN on the floor feel like somebody needs to go out to the hospital, unless it's an emergency, like they're coding or something, we go up there, we assess them, and then talk to the doctors and find ways we can do things at Graysdale. We are very capable of doing IVs and doing some things that we don't need to send people out to the hospitals for. So we will talk to the family and say, listen, let us try to do stuff here and handle the resident, because that's their best place. When they go to the hospital, they could be sitting in the walkway, down the hallways. They don't get a room all the time, and that just upsets them. So why not do it at Graysdale first? So that's where we've gotten penalized on some of our quality measures. We have the RNP program that we have revamped that will measure greater successes with our residents. So that'll be part of it.
Yeah, and then my last question is, and this came up at the last budget vote for the amendment. IGT, it seemed to have come in a lot higher. Do you know why? I mean, I know that Crawford County is in the process of selling and Cumberland got out of the business. Has that created more IGT money? What's going on there?
Yes, so we obviously paid more and we're getting more back. So they're benefiting us greater for having to deliver more money to Harrisburg.
Okay, and I guess but then my next question is, and maybe you can't answer this, kind of theoretical. We're going to be down, if Crawford County sells, we're going to be down to just 12 counties in the nursing home business. At what point does it no longer become, I mean, I was here when the IGT came, went, and came back.
Right.
my fear is if it goes away, and seeing as how we're gonna be down to just 12 counties, is that something that's been discussed?
Right now, I'm not hearing any talk of anything. IGT is standing because they've actually incorporated into the CHCs, so the insurance companies that now handle Medicaid, because Department of Medicaid Services didn't want to handle it, they gave it to the CHCs. They actually are getting the IGT money to disperse to us. So,
Oh, so that's factored in as part?
correct, in our payment models that they pay us, correct? That's where the $652 comes from.
Right.
Yep. So they, and the nursing home assessment fees are also wrapped in there.
Okay. Yeah, thank you, that's all
So-
I had.
Go ahead, Karen.
I have just one question. Are we cutting into the agency nursing and putting more of our own people there, or are we not?
Yes, well, and I'm going to explain that on the next one that I have about the update on Affinity. So that should tie into that piece of it.
Because that's a problem I'm seeing all over the place.
It is,
Because I'm dealing with it every day, going from one manicure to the next, and
right, and they sold many of their branches. Yep. So I wanted to give you an update on Affinity. So they did come in and they.
Ask my question?
Sure.
Thanks. And did anybody else have questions before I go? With the stat, first of all, kudos on the survey. However, how does that really bear, because I hear that and I hear we are well below the national average. But how does that bear out in reality? Is it all or nothing, good or bad?
It's
Or
good.
does
So-
it really look at compared to?
So what happens is that survey then ties into our star rating. So last year, we had 4 deficiencies. So this year, 1 will fall off. This better one comes on, so that raises our stars. So hopefully we go to the 5-star survey. Under surveys, we get 5 stars.
Who did the survey? This is the Department of Health?
Correct.
Okay. Regarding staffing, the fall-offs and the comings and the goings. The RN supervisor and the RNACs, are they going to be replaced?
Yes.
And were the RNACs were to capture dollars. They were not hired to do, who was hired to do some of this, I want to call it accounting, but that's not the right word, credentialing, keeping track of who has the paperwork filed, who has done their education. I know that credentialing and everybody having all their files in a row and all their paperwork in a row. and
So
did
we
not
have
hire
staff
people to
development.
Do that?
Staff development handles all our staffing, credentialing for agencies coming in. My department, administration, does like credentialing for doctors coming in. We handle all of that aspect of it. They also, staff development works with HR and making sure that everything that's required is in their HR jackets. So they work together on that piece of it. We hired an informatics nurse, but that was somebody to update our computer systems and keep everything updated. The RNACs just do, so they really help out on the nursing floors. They're doing the care plans. They're making sure that the records reflect the actual care that's been given. They do the MDSs, which is where we get our funding from, 802s, 672s. So they are an intricate part of making sure the dollars come into Graysdale.
I thought that's why we agreed to hire them in
Yeah.
the first place.
Yep, and that's where we agreed, we put some LPNs in there who, instead of using RNs, we used LPNs.
And then the last question, comment, wonderings out loud is the FMLA. And I
Yes.
guess this is not just a you problem. I've heard this, other similar types of person care industries has the same issue. But remind me, when somebody gets an FMLA accommodation, is there a term limit on it? Or is there an is it a month? Is it 3? Is it 6?
So we do monthly.
So your requirement as an employer is every month we must have documentation. And then the IFMLA, case by case, or,
That one I'd have to add, I think it's the same. Yeah, I think actually FMLA, if it's a standard time limit, you don't adjust for that. Like you don't have to require a recertification because they're going out for a specific time period. It's the IFMLA that's usually the one where they can call off for 2 days every week during the month, or, so that's that you can require the recertification on.
if I had an answer, I'd love to have a brain trust to figure out how to handle that, to make work life better for people so they wouldn't have to take it, but.
It's a tough one. It was very good when it was put into place, and it is a benefit for everyone that needs it, but it's hard to run a facility or anything with, when they can have that.
Yes.
Just one more question. When you were out talking about employment, boiler operator,
Yes.
is that going to be filled? Because that's a necessity.
That's Mike Amealy's. It comes under Graysdale, but that's actually Mike Amealy's position, so that,
Because that's a specialty.
correct.
All right.
And I believe it is a union position, so I believe it would be filled.
Okay, are there any other questions?
All right.
Affinity?
Yep. So the update on Affinity. Affinity met with the employees to discuss the ins and outs of their job functions. This was back in May, the end of May. I met with them and we discussed my job specifics, the budget, departments, census, opportunities for units that don't have any residents on them, agency usage, union contracts as it relates to low starting salaries and lateral outside hirings, and then overstaffing in ancillary departments. So I'm going to take a few of them. The agency usage, so back when COVID was crippling nursing homes, we managed to handle the situation with reduced staffing, those that left for reasons due to the initial fear of COVID. We were able to stabilize and reduce our census. Once the vaccine mandate, COVID fatigue, and directions from the Department of Health that we needed to get more agency staff into Graysdale, no matter the cost, Graysdale began to struggle. We have too much agency, and we know that. A lot of places do, hospitals, other nursing homes. We've been working to cut the costs associated with their usage. We are working on reducing these higher cost agency staff while maintaining quality of care. We have renegotiated agency staff contracts and brought on 5 more new lower cost agencies. We are always mindful and balancing the fiscal needs of the nursing home so that the care is paramount and there is no taxpayer liability, thus ensuring the long-term viability of Graysdale. This is why we asked council for additional agency funding last year, and we could use that $1 million that you held back from us. Putting that out there. Affinity and I also discussed the starting salaries for new employees and those that apply with experience. I explained that management has agreed to all union contracts, but it still creates a challenging position. The starting wages, it's negotiated. Negotiations include discussing an increase in the starting wage, but that comes down with a trickle-down effect where everyone's salary would get adjusted accordingly. Then you have to think about the legacy costs associated with that substantial increase, possible tax increases to offset the funds and healthcare costs, thus bloating the contract, which neither side wants. Lateral hirings. This has come up several times in negotiations. Upon hire, we do not allow people with experience to move up to the pay scale other than the initial starting salary amount. Many times we are told that they do not want to start at the bottom since they have 10, 20, and 30 years experience. I can see this point as a union, the union's perspective, that their long-serving members get the benefit for having served the residents of Graysdale. And then we had discussed, positions in the ancillary departments, and Affinity felt that maybe housekeeping and life enrichment may have a little too many FTEs. And that is something that I myself am not willing to decrease, as the cleanliness and activities are directly reflect the lives of our residents. It gives them and their families comfort in knowing that their loved ones enjoy a clean environment and activities to enhance their life. This is all about the quality of life for them when they come into Graysdale. So those are the things that I talked to Affinity about.
Anyone have any questions or comments? Mr. Heckman?
They're interviewing staff, you said? Union staff and non-union? Okay, I agree with you. I don't blame the administration. I don't blame anybody, frankly, but the starting wages, and that's a union issue. I think the administration would probably be more than willing to work on starting wages. But unfortunately, and I know it's almost like a third rail in my party, But the thing is, the public service unions, they feel, well, if we do this, everybody down the line has to get exactly the same thing. And sometimes you just have to realize that you need flexibility, like in the marketplace. And we're in the marketplace, whether we want to be or not. The government's in the marketplace nowadays. And you have to adjust and adapt to the reality you live in. In the old way, where I know more experienced people usually sit on the negotiating, and they always make sure that the top end gets hit and the low end is like, meh, and I'll probably take some flack for having said this to you, but I'm only saying it because I don't blame you, I don't blame the administration, I don't blame the union, but I think the union, the public service unions have to take a hard, long look at the staffing issues we have. And I wouldn't be surprised if some of those issues are right across the board. I know in Harrisburg, I've talked to some people, and there's a lot of unhappy people, mainly at the starting end of things. And I hope it works out. I really do. But, I just wanted to comment to you on that. I think that, I hope Affinity, we'll see what they say, but you're right. We really can't do much. I'd like to see the agency nursing go away, but and everybody's trying their best to get it, but
Right.
we all have to work together to make that happen.
Right. And that's why we're looking and turning over every rock we can. We're initiating new contracts in that are half the rates. So let's see if they can get people in. But again, once they get word that another agency has a higher cost, they run over to that agency.
I know, believe me, and I know Sue knows that from Human Services and Children and Youth. Somebody gets up and then they want to jump to a different division and take the set, and it's just crazy. But let me find, at this point, I wanted to ask you, what's our bonuses? Do we still have some bonuses in effect out there? And I've lost track. What do we have right now?
Correct. We have the 2,500 that comes available on their anniversary.
The what? I'm
I
sorry.
think it's 2,500.
Okay. Is that their yearly anniversary?
Correct. And it's for 4 years.
And that's for all employees?
Correct.
That's the only one right now? Is that the only one?
I think so.
Recruitment and retention, but the recruitment is, sort of gets rolled into retention.
No,
That's what
I saw Mr. Steve talking, so I thought he usually has all the info on money. So I thought maybe he knew something. But anyway, no, I was just curious. Thank you for,
No worries.
I'm finished. Thank you.
Just one follow-up then on the agency question. I remember looking at the first quarterly report, you were burning through that line item. Do you know where you are right now at the end of the second quarter? Have you exceeded your budget for agency nursing, or?
It's very tight. I can say that. I can get you the figures. But we're trying to reduce agency staffing as much as we can and hiring at the same time. We've had a lot of success with people coming in through the CNA program. The problem is that they don't stay. They get the CNA certificate and then they go to the next place. So,
Okay, all right.
We become a theater.
yes, because there aren't many places that offer that program anymore. So
We may be the only one in the valley.
I think there's two. I think you're right.
Any amount of time?
Unfortunately, with the Board of Education, you can't require them to stay on because of what they considered a lower paying job. They have to have the freedom of movement.
I get it. Like, you can't, I get it, okay.
It's not like you can do for an LPN or an RN who goes to official schooling and we pay for it, we can require them to stay on.
Thank you.
Okay?
Okay. Decision aid and supervision tools.
Jesus, she's tall. All right, bear with me here real quick.
while you're rolling, do you want?
Yes.
Is there anything that you're gonna want to report on other than the civil service? Great news, because you're probably
Amazing.
gonna run out of time, is my
Yes,
guess.
I can do the decision aid tool tonight, and next month I can do the supervision tool as well, instead of trying to rush through both. IFMLA usage, I just wanted to comment, even where we're at now, before we changed to 30-day restarts, that rate had been up to 44% of callouts for IFMLA. So despite what the number is now, it's been cut, less than half, which is obviously fantastic. And so the procedures we put in place to deal with that, we will certainly continue to do. The other thing is Gary Rushman retired. He was our Director of Information Referral and Emergency Services.
How many years? I'm sorry.
36-ish, a long
I
time.
just wonder, I know he was here a long time, because I think when his boss left, I think I promoted him to
I think he's been in that job for 15 years.
smart, hard worker.
He's a good man. Okay.
While you're setting that up, how many people have you lost in the last few months?
In Human Services?
Yeah.
I don't have that number off the top of my head. We really kind of go in, I think I've noticed in these, cyclical patterns of, maybe we have 5 to 10 folks resign throughout the building in the course of a couple months, and then we go, a few months with almost no resignations, and it sort of just kind of continues on that cycle. I'm thrilled now that we're out of civil service. The biggest issue that I see that will help us with our hiring is it's twofold, the elimination of the delays. So we talked about this, when you apply to civil service, from the day you apply until you come into our door, it's anywhere from 2 to 4 months. So this will cut that time drastically. It's also complicated to apply through civil service for civil service jobs. So it's more complicated than it is to apply through the county. And so I remain confident that that will help us with our hiring numbers for sure. But we have, I've already hired someone to replace Gary. Her name is Chelsea Jones, and she worked at a private provider agency a long time ago, and then she worked in children and youth for years, and then she has been in Health Choices. And so she transitioned into this role, I think it's her second week. So I'm excited for her to be there. So stay tuned for her introduction at some point. Any questions about civil service before I jump into this? Because
Real quick. When does this take effect? And also, now that we have this, and the good, the bad, and the ugly of it all is, I was listening to the theme from Good, Bad, and Ugly by Hugh Montenegro. It's great. But anyway, I love that. I love that instrumental. But the point is, I'll get beat up for saying that, but the point is this. We probably will have an easier time, I would think, not jumping through their hoops, but at the same time, they were also a backstop if things got ugly or if there was a big problem. Now it's all going to be on us. And I'd assume HR is going to be intimately involved. So I'm not concerned, but I think there's going to be a concern that if anything develops or there's a problem, is the state still going to be overlooking us? I think it'll be looking over our shoulders, even though we're not using civil service.
there's some level of oversight because we are reimbursed for children and youth positions, for example. But as a recent example, when Chelsea applied for the IRIS director position and received that, she still had to go through the civil service. She had to be approved and certified by civil service. So it didn't matter that we all, HR and myself and Mr. McClure thought she was met the METs and was qualified, we still needed their stamp of approval, which to their credit only took about a week and a half or 2 weeks, but that's 2 weeks quicker. I could have had her start in the job had she not had to be approved by civil service. So that won't, like, that's a step that will be eliminated in the
Okay,
future.
So that step will be eliminated.
Yep.
But everything else is in play. For example, let's say you get a complaint on a caseworker.
Sure.
You still would have to probably go to regional and refer, well, depending on the complaint, you'd have, regional would still come down and probably have to investigate it.
So if you're talking about children and youth, it certainly depends, but the primary reason we were able to get out of civil service is we already have career service regulations in place. And so those essentially just replace the civil service regulations. So everything we do for career service folks, it will be the same way for civil service positions, which certainly are primarily all of children and youth and early intervention and aging, drug and alcohol.
Okay, thank you.
Okay. So I just wanted to give a little bit of a super brief overview, since it's been a little while and it's a complicated conversation. I'm told that you'll be underwhelmed by this, so, brace yourselves. There's no big fireworks here, but here we go. So as we've talked about, both of these tools utilize predictive analytics, and we're only using our children and youth data as a reminder. And these predictive risk models are machine learning tools. So they are trained on all of our historical data to estimate the risk of an adverse outcome happening in the future. In other words, how likely is it that something bad will happen down the road? And in the case of children and youth, both of these tools, the risk score, or the complexity score as it's called in the supervision tool, help us to predict how likely it is that a child will be placed in out-of-home care within the next year. So it's a long-term risk score, which will come into play, and I'll talk about a little bit more then. So right now, the way we are using it is for quality assurance only. I think we talked about this briefly. So currently our screening unit of 4 folks, they receive referrals from Childline. They review that information. They make determinations if they need to make additional collateral phone calls or do any follow-up. And then either a decision is screened in for further investigation or it's screened out. And if it's screened out, the screening supervisor has to give his stamp of approval on that. And if, for example, we're screening out 500 referrals a month, you can imagine that's an awful lot of referrals that one person has to review to make sure he's comfortable with us screening out. So that's where the decision aid tool and the risk score that it provides is assisting that supervisor in being comfortable signing off on those decisions more quickly. So I think what's important to remember is that our caseworkers, whether it's our screeners or our investigators, they're looking at imminent safety and risk threats, right? So they're looking at how likely is it that something bad's going to happen right now or in the very, very near future. So the risk score, as you will see, is still that long term. So it's still that likelihood of removal from home within 1 year. So I'll explain that when we get to the tool in a second. But so in other words, if a youth scores high or very high, and you'll see the breakdown when I flip to the tool in a minute, it means that they're at long-term risk over the next year of being removed from home. So there are times when we screen out high risk and very high risk cases as scored on this particular tool. But what we've been able to do, because there's not necessarily any imminent risk. So for example, you might have an adolescent and there's a lot of parent-child conflict. There might be truancy, right? So if it's a 16-year-old with truancy, that's not necessarily somebody who's at imminent risk of being harmed at home. But what the high or very high risk score would be telling us in that particular case is you're going to keep getting calls about this youth and family, and or this youth is going to end up needing to be placed in out-of-home care within the next year. So the best part of the tool is those cases in particular, if we had been inclined to screen them out, which we feel we can do safely, Now we can intervene in terms of community services, diversionary services. We can put things in place for the family and the youth so that hopefully they won't ever be re-referred to children and youth. So that's where we're really utilizing it, but that's a key difference to understand. All right. Bear with me since I only have one screen. Okay. So so this is a demo tool. So it is, wait, hold on, sorry. I'm not tech savvy. I think I need to stop the slideshow. Or I'll just close it out. Well, Ms. Sembo, it's on my computer screen. Okay, here we go, great. Let me go back, thank you. So this is a demo tool. So this is all, I don't want to say fake data, but it's, it could be data that's pulled from, different case examples, and it's able to be shown anywhere. So I'm going to show you the decision aid tool. So currently, our screening supervisor, again, he's the only one that actually uses this number. So this is the screen that he gets. And I'm going to enter, I have a couple different examples, but I'm going to give you a high-risk score. Here's where the fireworks don't go off. But this is the tool, which I still think is really cool. So let me give you a quick sort of overview of it. Obviously, the whole point of this tool and the supervision tool, other than the scores that are generated, are that they are easy to use and easy to understand. And I believe the word Rima and her folks use is intuitive. So while I have a guide and a cheat sheet, a caseworker or any one of us should be able to go into this tool, if theoretically you had access to it, and within 5 or 10 minutes, have a complete understanding of it with no instructions. So our scores range from 1 to 20, and you can see the color coding of very low, low, et cetera. And they go all the way up to, it goes from very low to very high. You see at quick glance, it gives you the referral date, the family's name, and the client. And so I'm hovering over where it says alleged victim, and you see it provides just a little bit of additional information that it's the identified child within that incident. And for client Elizabeth Orange, age 43, it says that she's a parent. When you hover over that, it tells you that it's mom. And obviously it gives you the demographic info. So remember that we are only using our children and youth data for these. And it does not, the tool does not consider case notes, anything that happens outside of Northampton County. It's not using any court records or any outside data sources. So let me scroll up just to, some of that's on there.
So then what does it use?
So it uses all of the information that is contained in our CAPS system, which is the child welfare case management system that Northampton County and about 53 other counties utilize throughout Pennsylvania.
So if it's a fresh, brand new, never been in the system case?
So what it does, the tool is, so the family might be new to us, but essentially based on all our historical data within CAPS, the tool was trained so that, say there's 20 criteria that the tool's utilizing. Things like prior referral history, prior removals, parental substance abuse, parental mental health. The tool pulled all the data from our like 5 or 6 years in CAPS, and it looked at which children were ultimately removed from the home. and that was able to build this predictive model that took all those factors and figured out this one's most important, this one's second most important, and weights them essentially. So some of that will be described in more detail in the methodology report that will come out hopefully by the end of the year. So super technical questions I can't answer, but we will be able to get them answered. So basically, when this referral comes in, it can pull based on, the case history that's involved with this particular family. So mom has mental health, dad has substance abuse, there's domestic violence, and that's how the score is generated.
But again, if there's nothing else in the system, and I'm just doing the intake, will it just pull that data from the intake as I present it and add to the system, and that gets a point of its own? Or is it only from prior?
So I'm not sure I understand your question, but
A
let me,
brand-new referral, never been in the system before.
right, so let me try it this way.
No history anywhere of anything.
Right, so-
Other than I intake and say,
Yep.
mom has an alcohol history, dad has bipolar disorder. Like,
That's what it's
I'm
pulling.
that. So it will create that data.
Correct. So whatever data was in the allegation from Childline, that's what it will pull and look at. Yep. And definitely one of the most significant top risk factors is prior history and prior removals for sure. So, which I think is intuitive, so,
Madam Chair, can I ask a question?
Yeah, sure.
Real quick, Sue.
yes.
You said prior history, I understand. But, for example, let's say there was a child abuse referrals, and it was unfounded, like could have been 2 or 3. That's expunged, right? So would that show up?
Well, that's a
Because
great,
that's supposed to not be.
Correct.
That's supposed to not exist anymore.
it's a great question. So the expungement rules and laws have changed a little bit. However, it's still a problem because even with the change, maybe it changed, I've lost track, maybe it changed 2 years ago, right? So it's still everything before that was expunged, and some things are still expunged. But the way it's done in CAPS, and the tool can factor this, there's a tab called incident number. And so say there was 5 prior calls and they were all expunged, we wouldn't know that, except that when the next referral comes in, it says incident 6. So the tool knows that there were already, even if they were expunged and we don't know anything about them.
Doesn't specify anything other than there were 5 incidents.
Right, if that data, that particular family's data would not necessarily be in the system, correct? Yep, but because the,
The solicitor was okay with that? I mean, I'm only asking because if they've changed the laws, that's great. I know children and youth could get really beat up in the past, big time, because of the expungement business. In fact, people have sat in a courtroom with the lawyer, not that I'm citing personal experience, but that, was this expunged? If that's the case, why is this paperwork still in your county? So I just wanted to ask because I'm curious.
No, obviously, it's our intent to follow all the rules and regulations, but the system is designed that it thankfully for us has a built-in number to each incident. And so you're correct, that we wouldn't have any paperwork or computer, files on that particular family if it was all expunged, but we would at least know that there were 5 prior referrals.
Thank you.
Can I ask a
I have a question. If a family moves from Luzerne to Northampton, does that history come down with them?
It does not. Ultimately, Rima and her team have long wanted to build a statewide tool. And so they had contracted with the state to analyze Childline data to see if that was robust enough to generate the same kind of accurate model and score. And honestly, it's with the change of administration at the state level, I don't know where that lies. We decided to proceed because things take time and they take more time at the state level. And so we have this now. So down the road, ideally, that would be a statewide system. For now, it's not in our system, so the tool doesn't recognize it, but we don't have access to that anyway. It is a significant flaw in my opinion, in the system to not be able to have access to that kind of information.
That answers my question, scary.
Yeah, families move around,
Yeah, to avoid that situation.
Absolutely.
correct.
So, to Mr. Heckman's point, I'm sorry, I'm having a day. To Mr. Heckman's point, if is there any bias that's generated with seeing that there were 6 previous reports, but not being able to see what those reports were?
So staff, so bias is addressed throughout a lot of this, right? And so we know that humans are biased.
Yeah.
We know that data is biased. Our data, we like to think, is less biased because it's only pulling CAHPS data, like Allegheny counties, I think we've talked about that. They pull like 80 different sources of data that include like criminal history that has its own biases, built within the system. But together, human judgment plus this tool, the hope, obviously, is that it reduces the biases that end up, impacting our work. And I think many nice things about having the tool, but one of them is that we have a meeting, I think, in about 2 weeks to review with REMA what the first 6 months have looked like. So I don't have that yet. Like they've run all sorts of analytics on the back end, right? So how many high risk or very high risk did we try to screen out that we should have screened in? So all those sorts of things. So that was, I'm sorry, you asked about bias, but tell me your question again.
So you're saying that there's human bias, that there's not necessarily bias on,
Oh, you asked about the 5 referrals.
yes.
If a family-
So I guess what I'm trying to say is the bias only human generated, or does the system itself generate any bias in delivering the data?
So when the tool was trained on the historical data, if, for example, there were 100 cases where, say, 5 referrals happened to be like a magic number, where like after 5 referrals, like that's when you should have done something, that will be factored into the tool and to the number. But the screeners who are deciding whether or not to screen in a case for investigation or screen out a case, thinking that everything is safe and the family's okay and it's not a children and youth necessarily issue, they don't have access to any of this information. Now, they will have access to the fact that it's the 6th phone call about the family. So I think what we all would say working in children and youth is that the more calls we get, the greater the risk and we need to go out. So I don't think that the tool necessarily will validate or invalidate that specific kind of example.
Go kind of either way, because either somebody's making allegations that aren't sticking, or the person who's having the allegations against them is doing something to not make them stick. Do you know what I mean? Like,
I do, and I think like the custody cases and are some of the biggest problems, like when families call, obviously, mom's calling on dad, dad's calling on mom. Those are the hardest. I mean, we might get a ton of calls and there really might not be a child welfare problem. But I think what the tool is teaching us is that it's not a CYF case and we're not going to open for services if there's no imminent safety risk. But maybe there is some community service we can put in place for this particular family that would help alleviate some of that conflict. I mean, we're not going to solve all custody problems. I know that, but
no, definitely not, and not with an imperfect tool either.
No.
You know what I mean? So
yes.
But I can imagine that if there are that many calls, that it should throw a red flag up as to what's going on in the household that's generating this. And the other thing that I wanted to ask was, is there artificial intelligence that's used and driven in this, or is that not a component?
No, it is AI, yep, yep.
So with AI, it learns, and so how does this system learn? Like it's a predictive tool. So over the usage, like let's say in Northampton County, would it develop patterns that say like, well, in this particular household, there's a pattern here, or in this particular community or this particular demographic, we've seen this pattern proliferate, and then use that predictive modeling to address the patterns in those specific demographics?
So without getting into the weeds of some of those technical pieces, I can speak broadly and say that the tool is basically updated on a daily basis, right? So every day, our Evenco is the company who oversees CAHPS, which is our data system in children and youth. So every day, Evenco gives us a data dump of all the data from the last 24 hours. So every day, that's put into this system somewhere in the computer world, and that generates updated scores. So for example, over the life of a case, that risk score could very well change depending upon what is occurring within the household and what the if there's a paramour added or a spouse added, or mom got mental health treatment or dad got substance abuse treatment, like that risk score can start out very high, and over the life of the case, it could end up going down to much lower with interventions. So I think the answer is that yes, the tool can discern some of those things. There's no, it doesn't spit out anything that zip code 18020 is a red flag, or that kind of thing. And race is not one of the factors in the tool. So that's not even
Yeah, because that
being looked
generates
at.
bias too. So I was, because I was concerned with the decision aid tool score and what the implications would be for certain demographics of individuals.
So before we ever took this on, in addition to talking to council about it, I think I've talked here about the community outreach that we did. Because generally speaking, our Black and brown communities are certainly fairly in fairness to them, they are skeptical of things like this. And so the county executive and I and some of my other folks really tried to vet this with leaders in our Black and brown community to be transparent about what we were doing, why we were doing it. And I think I told the story, somebody asked in one of our forums, like, well, you're spending all this money. If in 6 months you see the tool doesn't work, are you gonna keep using it because you paid for it? And I said, no. It's like, it's like, to me, it was outrageous, but I understand the question. And so Rima and her folks, part of our ongoing contract with them on a yearly basis will be that they will be not constantly every single day, but they will be routinely and regularly reviewing the data, reviewing the outcomes, and reviewing the tool to make sure that it's still predicting accurately to whatever the statistical, whatever that magic number is to be statistically significant, and to make sure that there are not any biases. I think what we're more likely to find is that we're going to be able to fix some of the human biases that people might not even be aware that they have. So
That would be good.
it would be good.
But it's really interesting how AI is really creeping into a lot of different departments and tools that government can use.
So, I think the fascinating thing is, one of the things is that the tool is only pulling data from what our folks already have access to. Okay, but if I'm a caseworker, I'm not, and I get, if there's 4 screeners and we get 1,000 referrals a month, I'm on average, that's a little higher than we get, but for easy math, $250 apiece. I don't have the capacity, the bandwidth, the time, the brain power to go through all of these things to figure out, how significant is mental health, how significant is that? So really it's about making things more efficient, and being more confident in some of the decisions that our staff make.
Oh, yeah, this is my last question. So if somebody did have, like, let's say, data from another state that they brought, because they have their own paperwork or whatever, can somebody who's using this tool enter that data manually to impact the score, or no?
No, but what will happen is if this tool only is pulling from like that initial Childline referral that comes, it comes through Childline and it gets uploaded or downloaded into CAPS. And that's what the tool is pulling from. So that's all this tool uses. And so there's the only manual entry that, that you're really in the weeds, but the only manual entry I'm aware of is when we know, say we're familiar with a family and we say that's not the right house number, or that's not that kiddo's date of birth, but there's no other manual entry into that part of the
Yeah,
system.
because I thought Mr. Myers brought up a good point about people who cross county lines or state lines or something like that, and they move so that they can't.
It's why a statewide system will be so much better. And for example, one of the things that this tool has helped with in Colorado is reducing near fatalities and fatalities. The problem that we have had this year, and it's a whole other topic to get into another night, but we have had more near fatalities this year already, double what we usually average in an entire year. And they're largely related to marijuana and edibles and gummies. I mean, there's some others, but that's like it's probably 60 to 75%. But the biggest problem is the tool would not have helped us with those particular cases because they were not involved in children and youth before. So we weren't working with them until the child had a near fatality. Do you know what I mean? And so, so a statewide tool would certainly be even better, which we will now be ready for if that comes to fruition.
How interesting. Thank you.
You're welcome.
Mr. Myers has a question, and we're at 10 after 6, and you didn't even get past the first page. So how would you like to proceed? And I guess
this
I'm
is the
wondering, 'cause
page.
I know that you really want to give a good presentation on this, and I want to hear it, but, you know, it just brings up so many questions. So
Mm-hmm.
is there something that we should be looking at before you come so that we don't have this many questions? Like, is there stuff that
I
you
don't
should
think-
send us to do our homework?
I think we could talk about this every meeting for a year, and you would still have questions, and frankly, some of them would be repeated because it's just one, I mean, I've been at this for 5.5 years, and sometimes I still have to go back and reread my information to answer some of the basic questions I know will be asked. So this is the only page for the decision aid tool. I mean, this is it. That's why there's no fireworks. It's just super simple.
Is there any way to do, I don't know, like that you could put some cases in and we could see how it populates a score, or would that?
Oh, yeah,
be a
let me give
way-
you another one.
I'm sorry, I know you want to ask a question. I mean, let
You can
Mr.
ask while I
Myers
put
ask his
numbers in.
question.
Yeah, go ahead.
This program doesn't categorize race, correct?
Race is not included in this tool as a factor, correct?
That's what, I just wanted to make clarification on that, because we are mentioning black and brown people.
Yep.
My a bell went off in my head when you presented this before and said, only thing we get is data, we don't get. What?
I didn't catch that last part.
This is all database, it had nothing to do with race. And I
Correct.
remember asking that question.
Correct, yes.
That's why my community got nervous.
Oh, and it's rightly so, which is why, and Rima will tell you, she will not work with folks who are not completely transparent with their governing bodies, with their communities, with their black and brown communities, because it just doesn't, it's not ethical. And that's why we picked essentially researchers to do this with.
Hey, Lori, can I ask a quick question?
Can I ask one first? So wasn't, as a follow-up to Mr. Myers' question, wasn't that the whole purpose in getting this, is because we wanted to get something that would eradicate racial bias or minimize? I mean, now, like, wasn't that the entire point of why we
Minimize
did
is
it?
eradicate is not, but minimize, absolutely. Yeah, the big highlights for me were minimize our racial bias, minimize trauma to families who don't warrant a knock on their door and investigation, and not miss the high and very high risk kiddos. But minimizing racial bias was top of the list.
Was the intent.
That was the biggest question I asked when
Yep.
you brought this forth because of that.
Yep,
And I remember you saying no, and I was happy to hear that.
yep.
Go ahead, Ron.
Just, when you get the company, who's the company that collects and dumps?
Oh, Avanco.
Thank you. Do they include criminal court information?
No, it is only the information from Childline and from our own child welfare system.
Oh, so you don't get anything that the
No.
court would have done?
No, and I think what's most amazing about the tool, so Allegheny County, again, they have over 80 data sources, and I mentioned some of them. Our tool, built with just our child welfare data, was just as predictable and reliable as Allegheny County's tool, which was amazing, because part of what Rima wanted to demonstrate was that this could absolutely work in a much smaller county, town, city. Big, yep.
So then you did this, you said you.
Oh, so I put in another referral number for you.
Low number.
So this is a very low. So what will happen, this is a good example. So if I'm a screener, now I don't, the caseworker, I don't see this information, but I see, whatever the allegations are, maybe there was, I don't know, mental health issues for mom for this referral. So if I'm the caseworker, I say, I've looked through the file, I called the school, I'm comfortable, we're gonna screen this out. I don't think this is a child welfare issue. This is what would go to the screening supervisor's desk for review, because he has to then click the button that says supervisor agrees with screening this out. And remember, the natural inclination is to screen more in, because it's scary to screen out, even when we think it's okay. And so instead of the screening supervisor having to reread an entire file, the business process we came up with REMA's assistance based on all of the data and the history is that anything that scores very low or low, that screening supervisor can be comfortable just signing off on without having to read the entire file. So the screener already made that human decision. He utilizes the tool to say, okay, I'm comfortable with this as well. And I can find it for next time, given the time constraints, but we have the percentages of, from each category of kids who end up being removed. So it's like, if you have a very low risk score, there's like a 1% chance that you will end up within a year being removed from home. And I think if you have a very high score, it's like 38%, something like that. So that's where kind of the values range. So for medium, which is the yellow, that's where the supervisor would say, okay, I'm comfortable. They went out to do an initial visit. They saw the youth. There's no bruises, there's no marks, whatever. So I'm comfortable with that. And the high and very high, even if we're comfortable screening out because there's no immediate imminent safety risk or threat, that's where we say, well, what community services or what diversionary services would be helpful for this family?
But would you still not offer those in the gold range?
No, it's just entirely dependent on the case. So that's just sort of the yellow has always been the gray area. And
Biggest part of your.
yep, it absolutely is. So what we will find in the 6-month review is sort of like how many of these were screened in and ending up being validated or indicated or founded versus not. And so I'll have more to report about that in a few months, probably.
Do you have anything else to add from a director's report, as we are pretty much out of time? Anything that we might have missed not regarding this tool?
I don't think, so. Really, I think the Gary Rushman was the only other big news, and that was big news. So I'm happy to wait to do the other piece till next month to do it justice and allow for questions.
Any other questions for Susan
Yep.
before we go? Okay, then we'll adjourn the meeting.
Thank you.
Sorry we didn't let you get
Really
past.
interesting.
That's why I let Grace still go first.
Yeah, we haven't heard from them in a while.
Ms. Sembo, I'm not stealing your cords.